Okay, thank you, Steve. Can you hear me?
Yes.
Perfect. And you can see the slide
Yep.
and it's moving. Okay, perfect.
Yep.
Thank you, everyone. Welcome to the ICOS seminar in Cardio-Oncology. My name is Dinesh Thavendiranathan. I'm a cardiologist and the director of the Cardio-Oncology program at the Toronto General Hospital in Toronto at the University of Toronto. My interests are in advanced cardiac imaging and clinical trials in the field of cardio-oncology. And another area of interest is in multiple myeloma, given the burden of patients that we see. And so today, the presentation is on cardiovascular disease in multiple myeloma. Cardiovascular, I'm using as a broad term here, thinking about truly myocardial and vascular disease, as well as venous disease as well, which is both thromboembolism as well as arterial thromboembolic disease. So today, over the next little while, what I hope to talk about is just multiple myeloma generally, just provide a bit of background, discuss the incidence and drivers of cardiovascular disease and thromboembolism in patients with multiple myeloma, and then wrap up by discussing risk assessment and risk reduction in these patients. Then we can take some questions. And I think we have a number of experts in the field on the call who can also help with answering some questions. So I'll start with just a very general background. I will be honest, I'm no expert in multiple myeloma. It's a very complex disease, but I'll just provide some big picture, just some general knowledge that I use when I see these patients who are referred to me for cardiovascular complication. The first is that multiple myeloma is the second most common hematological malignancy in the United States. It's a plasma cell disorder that's associated with clonal plasma cell proliferation. And this results in production of monoclonal proteins that can eventually result in organ dysfunction. In the United States itself, there are approximately 32,000 new cases and approximately 13,000 deaths. The multiple myeloma tends to be a little bit more prevalent, although the incidence is a bit higher in men compared to women. And if you look at the literature generally, the median age at diagnosis is approximately 70. I think the last two facts are important for us in the field of cardio-oncology, because as you would imagine, if you have a disease where it's more common in men and it occurs in an older population, naturally, these patients are at an elevated risk for cardiovascular disease, regardless of multiple myeloma or the treatment that's used for multiple myeloma. I think somebody's microphone is not muted. May I kindly ask it being muted? It's a lot of background. Thank you. So generally, patients with multiple myeloma present with a wide spectrum of symptoms. This includes, I've listed a couple here: anemia, bone pain, renal dysfunction, hypercalcemia. These patients tend to have neurological disease, and there are sometimes even isolated neurological disease, depending on the type of multiple myeloma. As I mentioned, it's a heterogeneous disease. It can be rapidly progressive. That's important to keep in mind when patients are referred to us and when we are making recommendations. For example, if you look at the patients with high burden of plasma cells in their bone marrow, about 80% of these patients risk progression to end organ damage within a short period of time. Generally, when I think of multiple myeloma, patients refer to me, we think of high risk versus standard risk multiple myeloma. And this decision is generally made by the oncologist based on cytogenetics, as well as some blood work, specifically the use of LDH. And then with respect to other terminology, when these patients are referred to me, there are two major categories that I see: those patients with newly diagnosed multiple myeloma, and then the slightly tougher population, those who have received prior treatment, whether it is immunomodulators or proteasome inhibitors or hematopoietic stem cell transplant, but unfortunately now have relapsed or refractory multiple myeloma requiring treatment. The treatment of multiple myeloma has significantly evolved over the past 4 to 5 decades. This is just a brief overview of how treatment has changed. Earlier on, the treatments were focused on the use of melphalan and prednisone. We've moved on to use high-dose chemotherapy with, again, stem cell transplant, autologous stem cell transplant. Then there are active novel agents. Earlier agents were immunomodulators, such as thalidomide and lenalidomide. And then we started off with reversible proteasome inhibitors, an example of which is bortezomib. Then we have moved on to having other agents. This includes drugs like carfilzomib, which is again carfilzomib, which is a irreversible proteasome inhibitor, ixazomib, which is an oral proteasome inhibitor, and then we have antibody-based agents such as daratumumab and elotuzumab. So the treatment has really evolved, and this really has had a significant impact on patients with multiple myeloma. So this is just looking at survival. This slide's a bit on the older side, comparing patients with multiple myeloma in blue at the bottom, comparing the period between 2006 and 2007 versus 2010 and 2012. This graph shows survival, and you can see that survival probability has increased quite significantly in patients with multiple myeloma. And a lot of this can be attributed to the improvement in the treatment options that I discussed on the prior slide. I think when we think about the field of cardio-oncology, generally, when we have had tremendous improvements in survival from cancer therapy, it just means that these survivors are at a risk of a whole host of health problems. And one that we deal with is, of course, cardiovascular disease, and it tends to be an important health problem that survivors generally of cancer seem to experience. And it's the same case in patients with multiple myeloma. This is a market scan database study. They had over 1,700 patients with multiple myeloma diagnosed over a 5-year period. And these patients were age and gender matched to controls. And these patients are those who have received more than 3 drugs, which is proteasome inhibitors, immunomodulators, alkylating agents, or anthracycline. And the median follow-up was 9 months. Patients were followed up to 60 months or 5 years. What I have highlighted for you in the red box are the cardiac events in these patients, and it's compared to those patients with multiple myeloma. I've provided the absolute numbers there. And on the right-hand side, you see the adjusted hazard ratio. So the risk of heart failure or cardiomyopathy in patients who are survivors is in the order of 2.5 to 3%. The risk of cardiac arrhythmias, for example, is 4-fold higher in patients with multiple myeloma. The development of cardiovascular disease in this patient also contributes to poor prognosis. This is a combination of a set of clinical trials in multiple myeloma. And this asks the question, what are some of the early causes of mortality in these patients? And of course, infection and renal failure seems to be a major contributor. But as you can see, early MIs, cerebrovascular events, and heart failure contributed to about 8 to 13% of deaths in these patients. So the development of cardiovascular disease is not benign. The second major group of disease that we see that may be relevant to us is thromboembolic disease. And my focus in this is going to be a little bit less because I find that as a cardio-oncology person, at least in our program, the thrombosis clinics as well as the oncologists themselves deal with this, but I think it's important for us to be aware of this. This is, again, a large study, patients in Sweden that looked at the risk of venous thromboembolism and arterial thrombosis. And in patients with multiple myeloma, there was about a 7.5-fold higher risk of venous thromboembolism, even within 1 year, and about a 2-fold higher risk of arterial thromboembolism. Similar to cardiovascular disease, this is also associated with poor prognosis. So this is looking at death at 1, 5, and 10 years in patients who did versus did not develop venous or arterial thromboembolism. And you can see that the hazard ratio for death is significantly increased whether you develop arterial or venous thromboembolism. And this risk seems to remain at 5 and 10 years into follow-up. So I think I've painted the picture, hopefully, that multiple myeloma is a heterogeneous disease. The treatments for multiple myeloma have improved, resulting in significant increase in survival from multiple myeloma. And it's important to keep that concept in mind when we think about our recommendations for management of these patients. And I've hopefully shown that these patients are at an increased risk of cardiovascular disease and thromboembolic disease, as well as venous thromboembolism. So for me, the next natural question, yes?
Dinesh, sorry
Hi,
to,
hey.
yeah, Dinesh, sorry to interrupt. This is Dan.
Hey,
Thank
Dan.
you. Yeah, thank you so much for, this presentation. It's already fantastic. But I really want to emphasize the last few slides you just showed. Not every place has the, thrombosis center or whatever to support, who is on appropriate preventive therapy or what's the indicated treatment in those types of situations. So the fact that you have that support is really wonderful, but most other places don't have that support. So it's really up to us to recognize this issue of venous and arterial thrombosis. And I think that, there's been lots of discussion, among all of us over the past few years about, low molecular weight heparin versions or factor 10A inhibitors versus Coumadin, et cetera. And the complexity in this space is really high and it's very difficult to understand it completely. And to add to that is that all the major trials in the cancer space looking at arterial and venous thrombosis pretty much exclude multiple myeloma. And so what we know about those big trials does not include the myeloma population. So I think your recent 2 or 3 slides are extremely important. I just wanted to chime in there on that.
No, I completely agree with you, Dana. And I also, I think, recognize the complexity of managing this. And I've got some slides at the end, but we would tremendously value your input as well as to, what you do at your center for managing venous thromboembolic and arterial thromboembolic disease. So moving on, the next natural question for me was, what are some of the drivers of cardiovascular disease risk in patients with multiple myeloma? And hopefully us in the cardio-oncology space will have a broad approach to cardiovascular disease than just focusing on the drugs itself. And that's very relevant in patients with multiple myeloma. So there are patient-related risk, so the intrinsic cardiovascular risk that these patients may have, which I'll talk about, the demographics and the environment that these patients are exposed to. And then, of course, there's multiple myeloma-related risk. And there's the direct impact of multiple myeloma on the cardiovascular system, which perhaps we don't think very much of when we think about cancer, but very relevant with multiple myeloma. And then, of course, lastly, there's the impact of multiple myeloma therapy on the cardiovascular system as well. But when we think of cardiovascular disease in this patient, I encourage you to think beyond treatment and think of the whole patient into these 2 major broad categories. So I just want to briefly address each one of these separately. And the first thing I mention is the intrinsic cardiovascular disease risk factors and cardiovascular disease prior to even initiation of any therapy at the diagnosis of multiple myeloma. And this again likely reflects the patient population that develops multiple myeloma. This is again another market scan database. The party line is on the top, which is almost 50 to 75% of patients with multiple myeloma either have some pre-existing cardiovascular disease or cardiovascular risk factors. Now, I've broken it down here. On the left-hand side, you have patients with multiple myeloma, and in the right part of the table, you have patients who are matched and compared here. The ages were matched here, and you can see the incidence of hypertension and diabetes are higher, and pre-existing cardiovascular disease and renal dysfunction, which we think very little about in some of the other malignancies, is also significantly higher. So before anything, these patients are already intrinsically at a higher risk of developing cardiovascular disease. Then you have multiple myeloma specific risk factors. So you have myelomatous infiltration of the myocardium and pericardium that itself can contribute to restrictive cardiomyopathy. So should be in the differential diagnosis when we see these patients. They have hyperviscosity syndrome, which can contribute to thromboembolic disease, especially venous thromboembolism potentially, as well as restrictive or dilated cardiomyopathy. And also these patients have extensive intramedullary AV fistulas as well, and this contributes to shunting and high output heart failure. So when we think about multiple myeloma, amongst the risk factors and the treatment, we also have to think about multiple myeloma disease itself as being a potential pathogenic factor for the development of cardiovascular disease. Then the third category, which we focus a lot on in the field of cardio-oncology, is the impact of treatment on the cardiovascular system. And rather than going into individual trials, I'm going to try to present this through collated data from meta-analysis. So I showed this slide before, a significant evolution in the treatment of multiple myeloma that has really modified the face of multiple myeloma and the survival in these patients. So let's first talk about immunomodulatory agents. I think as Dan alluded to, the potentially one reason patients with multiple myeloma are not included in trials of prevention is because without anything, these patients are already at an elevated risk for venous thromboembolism. So prior to even immunomodulators being available, approximately 10% of patients with multiple myeloma developed venous thromboembolism. Although we attribute thromboembolic disease, especially venous thromboembolism, to immunomodulators, if you look at some of the earlier trials that looked at thalidomide or immunomodulators by themselves, the risk was not that much higher than the baseline risk expected in these patients. But where we started to see a big spike in venous thromboembolism is when these immunomodulators were used in combination, especially high-risk dexamethasone or prednisone, as well as cytotoxic therapy such as doxorubicin. And you can see in patients with relapsed or refractory multiple myeloma, a combination of thalidomide and doxorubicin is associated with pretty high risk of venous thromboembolism. And the same story is seen with lenalidomide at the bottom of the slide as well. Now, with respect to arterial thromboembolism, I think this is informed by two large studies in the multiple myeloma space, where patients received lenalidomide plus dexamethasone, again, in the context of relapsed or refractory multiple myeloma. And here there was about a 2 to 4-fold higher risk of MI and cerebrovascular events. So that's the consequence of this today with use of lenalidomide, especially specifically with the use of dexamethasone. There's a black box warning for increased risk of MI and cardio and cerebrovascular events in these patients. Dan, do you want to add anything before I move on to just proteasome inhibitors in cardiovascular disease?
No, you're doing great. Fantastic.
Okay, so I'll continue on. So the next is the specific cardiovascular adverse events in patients who are receiving proteasome inhibitors. As I mentioned, I'll show this using meta-analysis. I think it makes the point well. So the reversible proteasome inhibitor, bortezomib, there have been about 25 trials. It's used beyond multiple myeloma. And if you just look at the studies that were the randomized controlled trials and look at cardiotoxicity, which I've defined here, so it's a spectrum of heart failure, arrhythmias, and cardiac arrest. Initially, if you look at the summary odds ratio here, the summary risk ratio here, you see that there wasn't an increased signal for cardiovascular events, whether you're considering high-grade cardiovascular events or all-grade cardiovascular events, there wasn't a clear signal. Now, as I mentioned, these RCTs included patients with multiple myeloma and patients with other malignancies. And if you broke this down a little bit and looked at this carefully and compare those with multiple myeloma and the other population, and look at both all grade events and high grade events, you can see that there seems to be a higher signal in patients who are receiving bortezomib as well. So although the focus for cardiovascular events in many ways have been on the irreversible proteasome inhibitors, which I'll talk about, I would say in my practice, because of the greater use of bortezomib earlier on in the treatment regimen, I see a lot more patients referred to me with cardiovascular complication from bortezomib than from carfilzomib. So just keeping in mind that when somebody's referred to you with bortezomib, think that that could definitely be a contributor to cardiovascular disease. So much of the focus has been on, when it comes to cardiovascular complication, has been with irreversible proteasome inhibitor, specifically carfilzomib. Again, here is a meta-analysis, and I'm just showing the multiple myeloma population only. And what if you can look at all grade events on the left-hand side of the table and high grade events on the right-hand side of the table, in fact, the most common side effect that's seen in these patients is dyspnea. And some of this may be related to lung injury, but this has never been looked at carefully. There may be a component of diastolic dysfunction given the patient population, but I think this has been not explored completely. We see that congestive heart failure and hypertension are common in these patients. Again, greater incidence of hypertension than congestive heart failure, and a similar trend is seen when you look at patients with more than grade 3 events. Now, this is just the 3 major randomized controlled trials in this space, looking at cardiovascular events. And if you look at just high-grade events, you see about a 2-fold increased relative risk of developing adverse cardiovascular events with carfilzomib therapy. Now, I think with many of these trials, we really need to look at the details of the trials a lot more closely before we conclude that this is a bad thing with these drugs, and also keeping in mind that many of these drugs have really changed the outcomes in multiple myeloma. So that's what I will do, the 3 major trials in the next 3 slides. Just drill down into them and just explore this cardiovascular events a little bit more closely in relationship to the benefit of carfilzomib therapy. So what you see here at the bottom of the slide, this is just medical history, looking at pre-existing cardiovascular risk factors or cardiac failure. And these are the 3 trials comparing carfilzomib to the various different controls. And if you look across the table, you'll see that there's generally a good balance for hypertension between the 2 groups. The risk of cardiac failure in Aspire was a bit unbalanced, but in the other 2 trials, at least in Endeavor, it was reasonably well balanced. In Focus, maybe again a lack of balance here. And cardiac arrhythmias were similar between the 2 trials. So generally, both groups were starting off at a similar risk, perhaps a carfilzomib group at slightly higher risk. Then we looked at cardiovascular events in these patients. On the top, you have any grade events and high grade events at the bottom. And you do see an increased signal for a higher incidence of any grade and high grade cardiovascular events in all the 3 trials in patients who received carfilzomib compared to the control group. But I think as we think about cardiovascular events in the space of cardio-oncology, we have to ask ourselves 2 specific questions. The first is, what is the implication of this for the cancer treatment? And then what is the implication for this for overall mortality? And finally, how reversible is this cardiovascular events? So if you look at some of the implications for cardiovascular dysfunction or adverse cardiovascular events, and if you look at treatment reduction, this is cancer treatment reduction, very little of this resulted in reduced or alteration to cancer treatment reduction. Now, this may be because there wasn't strong involvement of a cardiology or cardio-oncology practice in guiding management of these patients. Now, if you look at treatment discontinuation, again, very little treatment discontinuation for cardiovascular adverse events. And finally, of course, what we care about is cardiac mortality in these patients, which is also important. And again, little difference between the 2 groups. So we are seeing cardiovascular events that are much more common. But if you look at its impact on cancer treatment itself, the impact seems to be not as much as we see between the two groups with respect to cardiovascular events. Then also the question is about recovery of these cardiovascular events. And the bottom line is that many of these cardiovascular events, in fact, do recover in the three landmark trials. So I think to put that into perspective, it's nicely shown here. So this is on the top, you look at progression or death from the treatment, in patients with multiple myeloma, comparing the carfilzomib group at the bottom and the control group on the top, and you can see that the curves really separate nicely at 18 months. Same thing in Endeavor, you see nice separation between the carfilzomib treated group and the control group. Then at the bottom is the adverse cardiovascular events, and here the focus was on heart failure, and you do see a slightly increased signal, but again, the benefit here seems to be quite remarkable. So how do we quantify this a bit to understand this balance? And I think this meta-analysis really did this nicely. And they looked at the number needed to harm versus the number needed to treat for progression-free survival. And you see on the top that the number needed to harm is much larger than the number needed to treat. So I think, to me, when I look at this data, what this tells me is that we have to keep in mind that these treatments have had remarkable impact on patients with multiple myeloma. So our goal should not be to stop these treatments, but rather to support the oncology program to allow them to complete treatment and whatever means we can. That may be prevention or treatment of cardiovascular risk factors earlier on, or early consultation on these patients when they are referred to us to start treatment that will help reverse some of the cardiovascular disease to allow them to complete their planned cancer therapy. So that's what I took away from this slide. So before I move on to risk assessment and risk reduction, I'll stop again. Dan or anyone, any questions or any comments at this point?
Yeah, Dinesh, I don't know if you're going to get to it, but we did a prospective study to define the number of events, and
it's coming up next then.
Yeah, so bottom line is that those studies that you showed were carefully done, of course, but they were also the ascertainment of cardiovascular issues were really determined by oncology research nurses. So the ascertainment of a cardiovascular event wasn't done by a cardiologist. So I think that the rates are going to be a lot lower than what it would be if you had a cardiology input into those particular studies. And as you also pointed out, dyspnea is a very common symptom, and they record dyspnea as an event that doesn't say what they did to evaluate it. So all the people that had dyspnea could have been heart failure, or it could have been pneumonitis, or it could have been something else, PE, but we have no idea what the nature of that dyspnea is. So I think that we have to be careful about those retrospective studies, because the ascertainment of events is much less than what we would hopefully expect.
Completely agree with you, Dan. I think on all the points you made, and I think important is that in the field of cardio-oncology, we tend to see this duality. We see the clinical trials, which the oncologists tend to live by, and perhaps feel that the risk may not be high. There's also the retrospective population-based studies where there's a risk for misclassification, and then I think the number of true prospective, carefully done studies like yours, which I'll talk about, are not as common. I think that is really the best way at carefully assessing this to understand true risk. And I'll show the data. I think somebody else had a comment or a question.
It's Joe. How are you?
Hi, Joe.
Yeah. So if you go back, you don't have to go back to the slides, but I think that it's important to point out it also flows through the studies, is that there's definitely a dose relationship between MACE, and that even on the charts that you showed, the people who got 20 or 27 milligrams per meter squared of carfilzomib versus the people in the 50s, all of the events are increased in the larger dose group. So it's something that we've recognized for a long time that you showed very nicely.
That's an excellent point, Joe. I think that's been mentioned. It's been a bit controversial. Like some studies have shown this, others haven't. But you're absolutely right. In some of the meta-analysis, the dose seems to be relevant as well. Sorry, Dan, did you have a comment?
Yeah, so to follow on with what Joe said, that's totally on the money. As usual, Joe usually is on the money, but the original carfilzomib-based studies were using the 20-27 dosing twice a week. And then they went to once a week dosing with 56. And then they also did a study with once a week dosing at 70. Right. And they actually had to close that study because of sudden cardiac death. And that study has never been reported that I'm aware of. So, you know, when you look at meta-analyses, you know, what we already mentioned about ascertainment is one thing. And then also what Joe just mentioned is really important, because at the higher doses, those studies haven't been published. And those cardiac events are more acute in the higher dose studies. That is clear.
Yeah, I agree with you, Dan. I think especially the 56 milligrams per meter squared dose have been associated also in meta-analysis to increase the risk of cardiovascular events. So completely agree with both of you. There's no other comments. I'll just move on to risk assessment and risk reduction. So I had this slide here. This is a review from Javed that looked at risk assessment in JAMA Oncology. The references at the bottom. So the first I'll talk about here is venous thromboembolism risk assessment. As Dan alluded to at the beginning of the presentation, something that's quite challenging to do, and hats off to those in the cardio-oncology program who see these patients and make these recommendations. So there are three major concepts when we're thinking about risk in these patients. The first is individual risk factors. Then we think about myeloma-related risk factors, and then finally therapy-related risk factors. And I think taking the systematic approach would be quite helpful. So individual risk factors that we should think about are, many of these are actually general risk factors for venous thromboembolism, including obesity, prior venous thromboembolism. There's endothelial damage because there's a central venous catheter, thrombophilias, immobilization surgery. So the general risk factors we think about, along with some that may be specific, such as central venous catheter, are the first set of risk factors to think about. Then there are these myeloma-related risk factors, which is including hyperviscosity and the disease status, and finally therapy-related risk factors. And this includes DEX, concomitant use of erythropoietin, combination of immunomodulators, and high-dose dexamethasone. And for some reason, the cytotoxic agents like using meds like doxorubicin seem to increase the risk of venous thromboembolism. So what do people do? And I think there's a lot of variability. The myeloma working group, again, not necessarily driven by strong evidence, but by just expert recommendations. Some of the recommendations are that those who are considered low risk, which in the recommendation was less than one individual, or myeloma-related risk factor 1 or less, that perhaps a low-dose aspirin could be used in these patients. In the higher risk patients, where they have 2 or more individual or myeloma-related risk factors, the suggestion was to use 40 milligrams of low molecular weight heparin, for example, enoxaparin, or full-dose warfarin. And then in patients who are even at a higher risk, the treatment was about the same, which is low molecular weight heparin or full-dose warfarin, keeping in mind that many patients may have renal dysfunction and that we may need to adjust the dose of low molecular weight heparin. Now, important to also keep in mind that despite these preventive strategies, still a significant proportion of patients go on to have venous thromboembolism. So if a patient is referred to you with symptoms, with multiple myeloma that may raise concern for venous thromboembolism, just because they're on one of these prophylactic therapies, you shouldn't discredit the fact that there's the risk is reduced, because the risk remains still elevated despite using these agents. I'll stop here for a second again, because the rest I'm focusing on cardiovascular disease, so maybe important to bring this up and discuss this a bit more. Dan, just perhaps what you guys do, and Joe, maybe what your group does when it comes to managing this and making recommendations may be helpful.
Yeah, I mean, I think this is a nice review at the time. I believe the myeloma working group has updated their general guidelines, and Coumadin is not even an option in terms of prophylactic therapy anymore. So it's a little different than this particular slide. I do think that this area is really not known, and it's a real challenge, because with the efficacy and benefit in general of factor Xa inhibitors, you know, I'm generally inclined to go that route if I have any reason to use one. But I think there's also very good data for low molecular weight heparin.
I agree, and I think Joe as well, just generally your use of DOACs in these patients, this is something that comes up all the time. So Dan, I guess from your side, is that the go-to based on renal function for primary prophylaxis in the higher risk population?
Yeah, I mean, I have a very low threshold, definitely.
Okay.
Yes.
Fair enough.
Dinesh, it's Alex here from London. I would also echo that. I think committing people to daily low molecular weight heparin long term is a very big burden on them in terms of the injection burden. And therefore, I would also advocate using a direct oral anticoagulant and usually a 10A inhibitor if I feel it's reasonable and needed, or if they have a DVT or PE and that they need treatment. I very rarely would use a low molecular weight heparin in this situation.
Yeah, I think the one thing about DOACs in general, I mean, there is a lot more drug-drug interactions with dabigatran, so I tend to shy away from that.
Fair enough. That's helpful. Thank you. All right. So moving on to cardiovascular disease risk assessment, and I want to present this study, which provides some prospective assessment of cardiovascular events, as well as potential markers of elevated risk that we can consider within our cardio-oncology program. So this is a prospective observational multi-institutional study. It included 95 patients. 2/3 of these patients were on carfilzomib, a third on bortezomib, and the decision of the drug was based on the oncologist who was caring for these patients. One of the goals of the study was to define cardiovascular risk factors and outcomes in these patients and compare between the two groups, and these were patients with relapsed multiple myeloma. And the cardiovascular adverse events that were considered in this study are listed at the bottom. So it wasn't only heart failure, but it included hypertension, arrhythmias, it included acute coronary syndrome, pulmonary hypertension, and venous thromboembolism. And in the study, they provided the incidence of each one of these events separately. So this is one of the main findings of the study. First, on the right-hand side of the slide, you would see that cardiovascular adverse events in a prospectively, carefully elucidated group of individuals, looking at these patients carefully. 51% had a cardiovascular adverse event in the carfilzomib group, and 17% of the patients in the bortezomib group had an adverse cardiovascular event. It's also, the timing was also an important finding. The median time to the first onset of event was 31 days, and 86% of the events occurred within 3 months. And I think this has major implications for the need to follow these patients. The highest yield from an oncologist with respect to identifying cardiovascular events or from a cardio-oncology program that may be following these patients carefully during their treatment, the most important period seems to be in the first 6 months, or at least in the first 3 months, where most of these events occur. So what if you look at the events here, again, this is you can see a cumulative incidence curve here, and if you look at the 6 month time point, there seems to be a flat line after the 6 months, and this is looking at any event in blue with carfilzomib and just congestive heart failure, and at the bottom you see bortezomib as well, and there were differences between the group as shown here. Again, as I mentioned, 65 patients in the carfilzomib group and 30 patients in the bortezomib group. So then they asked the question, what increased the risk of developing cardiovascular events in these patients? A threefold increase in patients who are receiving carfilzomib versus bortezomib. What was really interesting and potentially an important takeaway and practice changing in many ways is the fact that the elevated baseline levels were associated with a fourfold increased risk of heart cardiovascular disease. What was even more interesting was that if you followed BNP and if you have an elevation in BNP, that was associated with a 9-fold higher risk of developing cardiovascular events. Finally, if you had more than 2 risk factors, your risk was higher than having 1 or less cardiovascular risk factors. So I think this is clinically relevant for these patients that we see, and centers like ours have really taken this data to heart and have tried to do BNP systematically in patients who are about to receive these treatments with proteasome inhibitors, and use it as a potential triage to either follow these patients closely or refer these patients to our program. The other thing that was interesting that came out of this trial on the right-hand side is that they looked at baseline left ventricular ejection fraction. And we know data, for example, with anthracyclines and trastuzumab, there seems to be some relationship with baseline left ventricular ejection fraction and the subsequent development of cardiovascular events, specifically heart failure. But in this study, traditional left ventricular ejection fraction measures did not seem to identify those patients at risk. And Dan may have more data that he can talk about, but I wonder whether more advanced imaging strategies or even diastolic function assessment, whether that may have a potential role in identifying patients at risk for future events. So Dan, before I go on, anything to add to your study?
Well, I think, yeah, you kind of highlight this, but the issue of LVEF, if you're using that as a tool to follow patients, it really didn't add anything to the evaluation. And even when we looked at more advanced imaging techniques like strain and diastolic filling parameters, they really weren't that helpful, but the natriuretic peptides were. So I'm not sure how routine cardiac imaging is particularly useful in this population, but I do think that natriuretic peptides obviously are. And then I think when a patient develops obvious heart failure or acute coronary syndrome or some other major cardiac issue, then you can do the echo as part of that, of course.
I think from our side, that's the approach that the oncologists have taken. We're at their mercy for referrals to our program. So, generally they seem to have latched onto the biomarker approach than an imaging approach in these patients, which based on your data seems reasonable. Okay, so cardiovascular risk assessment. So, if a patient is referred to us, and sometimes these patients are referred to our cardio-oncology program for risk assessment, what can help? So generally, patients who have traditional cardiovascular risk factors, which is the older population, the uncontrolled hypertension, or smoking, chronic kidney disease, or high BMI, and of course pre-existing cardiovascular disease, including heart failure, coronary artery disease, some conduction abnormalities, and I think from Dan's study and some other data previously, potentially elevated BNP is a marker to assess elevated risk and has been used for referral in some centers. So those are patient-specific risk factors, and I think it's important to think about treatment-related risk factors as well. That includes patients who have had prior cardiotoxicity from proteasome inhibitors, patients receiving either cytotoxic therapy such as anthracyclines or combination therapy, or even just high-dose dexamethasone. So this was really nicely put together, work led by Dr. Alex Leon and with ICOS and Dan Linehan, that has really created a whole bunch of pro formas for different cardiovascular, different cancer therapies, and to assess their cardiovascular risk. And I think where this is extremely helpful is that at this point, there have been really very little guidelines for the oncologist to identify which patients are at elevated risk for cardiovascular disease or even thromboembolic disease, and make appropriate referrals to the cardio-oncology program. On the other hand, when patients are referred to us, it is difficult often for us to determine which patients are at elevated risk. So this has really been a nice addition to the literature. It really nicely breaks it down into prior cardiovascular disease, biomarkers, demographic and cardiovascular risk factors, previous cardiotoxic cancer therapy, current multiple myeloma therapy, as well as lifestyle risk factors. And then it breaks these risk factors down into sort of very high risk or medium risk. And then there's this at the bottom here, some guidance as to how you can use this information to determine where patients are high, intermediate, or low risk. And we haven't formally instituted this yet. Many of the parameters here are already used by some of the oncologists to make appropriate referrals to our program. But I think this will be a really nice structured approach. And those of you who haven't seen this document, it's already in press. I think the formal publication in the journal format should be coming out also soon as well. And those of you who are interested in multiple myeloma and just generally in the field of cardio-oncology, this document can be helpful in identifying patients at risk for multiple myeloma as well as other cancer treatments. There's also been this approach that was suggested again by Javed Maslehi in his JAMA Oncology review. Again, a very similar approach, looking at pre-treatment risk factors and then thinking of low and high risk cardiovascular regimens, and then instituting primary prevention strategies. And in the higher risk cohort, perhaps this is the cohort that may benefit from cardio-oncology expertise as available at each one of the sites. So now we have assessed risk, we've made the referral. What can we do during treatment to reduce the risk of cardiovascular events? And I think there are certain things we could consider. Of course, the simplest is to manage cardiovascular risk factors aggressively. But the second, I think, important concept is also fluid management. When I think there's differences in practice. When I talk to our oncologists at Princess Margaret Hospital, they tend to suggest that they don't use high volumes anymore in patients with multiple myeloma. But it used to be standard to hydrate these patients quite aggressively during their treatment, and especially in our cohort that have pre-existing cardiovascular disease. This may tip them over potentially into heart failure. And in those with diastolic dysfunction, this may be one of the drivers of dyspnea. It's also important from an oncology perspective to monitor these cardiopulmonary symptoms and make appropriate referrals. As I mentioned, hypertension is quite common. And I think the oncologists have realized this, and now have many of our oncologists have invested in blood pressure monitoring in their offices. And as in the cardio-oncology program, sometimes there are opportunities for remote blood pressure monitoring to monitor that effect and manage that quite aggressively. I think we discussed the issue of repeated imaging. Current literature does not seem to support benefit from this. But I think where I would be interested in looking at is in that dyspnea population, whether markers of diastolic function and diastolic filling changes over time and potentially contributed to that symptoms. And as I mentioned from Dan's study, there may be a value to monitoring BNP during treatment. So now we have, there are potential risk mitigation strategies. The patients now refer to you because they have developed cardiovascular disease. How do you manage this? And I think we still have to think about the mimics of cardiovascular symptoms in these patients. Many of the times I find that the oncologists rule this out before they send patients to us. But sometimes, I'm thinking about whether the shortness of breath could be PE or infection, or could it be driven by anemia. So I think a little bit more broadly than just pigeonholing into just cardiovascular complications in these patients that are related to the treatment. If it's carfilzomib induced, generally the carfilzomib is held until the adverse event resolves. We are quite aggressive in managing risk factors to get patients quickly back on carfilzomib therapy. And then for the other traditional risk factors, I think we generally follow guideline-based approaches. And if there's a plan to re-challenge these patients, we tend to be quite aggressive in carefully monitoring the cardiovascular status in these patients, careful follow-up and phone calls often to these patients during their treatment, and engaging them in managing the potential risk factors and potential side effects, such as their blood pressure and also early development of symptoms, so we can see them quite quickly in our clinic. So I'll summarize, and then maybe we can have more discussion and answer some questions. So generally, what I've said today is that patients with multiple myeloma at elevated risk of cardiovascular disease and thromboembolism. And this risk seems to be driven by pre-existing cardiovascular risk factors and cardiovascular disease, the impact of the cancer itself, and potential impact of treatment. And along with cardiovascular risk factors, I think it's important for us to also think about the treatment efficacy. As I've mentioned, I think several times, I've tried to emphasize that the treatments that I use today has really changed the landscape of multiple myeloma and survival in these patients. High-risk patients, as I described later on in my presentation, would likely benefit from cardiac assessment, aggressive management of their cardiovascular risk factors, and careful follow-up in cardio-oncology program. And just keeping in mind that these risk mitigation strategies will likely allow the oncologist to provide optimal cancer therapy and also prevent our survivors from being affected by cardiovascular disease, and cardiovascular disease contributing to morbidity and mortality. I think that's all I had, Dan. I'm happy to discuss further input and answer any questions.
Super, Dinesh. That was really awesome. You always give outstanding lectures, so we appreciate all your effort. There is one question in the chat room. What dose of low molecular weight heparin is advised? It's actually a very important question.
Yeah, so Dan, I think it seems to be just a prophylactic dose of 40 milligrams. But again, when we're using enoxaparin, for example, and again, it should be a renal dose dependent. And again, as I mentioned, we don't do this that much in our cardio-oncology program, so I will look to everybody else's expertise, Alex, Joe, and yourself, for some suggestions.
Yeah, I think it's kind of like dealer's choice. Whether you have a low dose prophylactic dose, or whether you have a twice a day full treatment dose, or whether you have once a day dosing that is 1.5 milligrams per kg. Those are all options. Many locations do whatever they're used to. So I'd be interested if anybody else had other opinions as to what the dose of that would be.
Excuse me. Excuse me, can I?
Yes.
Can I ask the question?
Yes.
Thanks for nice talking. I'm Dr. Shekarchizadeh from Iran, the first doctor in cardio-oncology field in my country. As I see in your slide, low molecular weight heparin, 40 milligram once daily. After that, it's wrote or full dose warfarin, INR 2 to 3. I think the better is 1.5 to 2, because this dose of warfarin is not matched to low molecular weight heparin. It is for prophylactic, not treatment dose. And as we know, warfarin is not proper, I think, in oncologic patients. And the oncologists prefer low molecular weight heparin or low dose warfarin. I don't understand the dose of warfarin in this slide. Would you please explain?
Well,
So I agree with you. I think these were the earlier recommendations, as mentioned by Dan from the multiple myeloma working group with respect to preventing the development of venous thromboembolism. I think I agree with you. There is a bit of a discrepancy. The doses suggested is prophylactic for low molecular weight heparin and therapeutic for warfarin. Again, not sure what the rationale for that recommendation is. Dan, any thoughts?
No, I think, like I said, it's an update. If you go to the myeloma working group document, which came out, I don't know, less than a year ago, they took that recommendation off. So Coumadin's not even there anymore. To your other point that you made at several places, in the PROTECT study and certainly in practice, although I think identifying cardiovascular events is super important, and also in the PROTECT study, we found that those that had cardiac events, and it makes perfect sense, had a worse overall survival than those that did not. And so detecting those events and preventing them with appropriate risk factor management is a critical element, and it shows where cardio-oncology can really have a benefit for this particular patient group. The other part is that in almost every, I think it was 29 out of 30 of those patients that were on carfilzomib that developed a cardiovascular event, they were allowed to go back on therapy when their cardiac event was managed. So they were able to continue therapy. Only one person was not, and that's because he had sudden death. So I think that you can manage the problems and the patient can continue on whatever is their best therapy.
yeah, so
Dan,
Yes,
it's
thank you.
Alex here from London. Can I make a comment and ask a question to maybe you and Dinesh, which is based on our experience and partly what I shared with Dan in terms of how we looked at the cardiac events in some of these myeloma trials. Because when we looked at the events and adverse events in the trials, which, as Dan said, were reported by the hematologists, one relatively common factor was a troponin rise. And I remember us debating, is the troponin rise an acute coronary syndrome, or is it a heart failure associated myocardial injury? And it's interesting that in your prospective study, it was the BNP rather than troponin that was the best biomarker for predicting further problems. And as a proteasome inhibitor, of course, we know the importance of the proteasome in the myocyte. And so one wonders whether you've got a sort of a pathology in someone with a diseased heart where maybe they're already got a hyperactive proteasome to deal with the pathology of their heart disease. It gets inhibited, and that proteasome inhibition leads to then some form of dysfunction that builds up over time until they present with an acute heart failure event and the troponin rise. Or with the IMID, it's a coronary thrombotic event, but it seems more likely that this is a direct myocardial toxicity based on Dan's PROTECT study. That's sort of the best data, and that the troponins may more reflect myocardial injury rather than acute coronary syndrome. But we've all seen acute coronary syndromes as well in these patients, but I get the feeling that it's more of a heart failure toxicity, but I'd be interested in your views.
Well, I think the other part that Dinesh, highlighted in several places is that especially people on carfilzomib, they actually do have frequently a hypertensive response, and it's a lot higher than what you would suspect. And I think that there may be a component of anti-angiogenic mechanism going on there. The combination of potent proteasome inhibitor and an IMID sort of has anti-angiogenic capacity. So I think that hypertension response it's an important factor. And in terms of biomarkers, I think that for all the typical cardiac biomarkers, there's not going to be one size fits all for all cancers. So obviously, if you're giving people anthracyclines, you may see some troponin elevations, as Daniela's data has repeatedly shown. And then, if you're doing trastuzumab-based studies, the mechanism may not be direct toxicity. And then, in the case of myeloma, proteasome inhibitors, I don't think that they are directly toxic to the myocardium, but they certainly, in the case of an acute coronary syndrome, you might see a troponin elevation. So, point being that a BNP or an NT-proBNP and troponin give you complementary information, and those one biomarker may be better in a certain population versus another, but in the end, it's usually the combination.
One thing I've also seen. Sorry, Joe, go ahead.
We're running out of time, but I want to make 3 really fast comments. The first is that by the time that most of the people that we see with multiple myeloma have been heavily pre-treated with multiple regimens, oftentimes with 1 or 2 or 3 previous episodes of high dose melphalan and auto transplants, which adds another dimension to the risk of taking care of them. We didn't even scratch the surface about combinations and using carfilzomab with pomalidomide and pomalidomide with daratumumab, which I think also has something with the pomalidomide increases cardiotoxicity to some extent. And then the third comment is always in the background, especially in heavily pretreated people who may have been out for a decade, is amyloid. Background.
Super. All right. Well, thank you all so much. Everybody contributed so much, and Dinesh, as always, stellar presentation. Thank you again for preparing all of that, and we really appreciate your
pardon me.
Contributions.
Pardon me. May I have a question?
Sure.
Excuse me. In your slide, I don't have see any of Novak, new oral anticoagulant. What is your opinion about them? For example, rivaroxaban or apixaban. Should we use them for the prophylaxis of venous thromboembolism in multiple myeloma? What's your experience?
I think Dan addressed the question earlier on, and I think his experience, again, we don't use it as much because we're not involved in the decision, but his experience is that I think they are quite appropriate to use in the prophylactic environment as well. Dan, that's what you said earlier on.
Sure. Yes. No, I think thank you all for your interest. We've gone over our hour, so we better call it a day so that people can move on. But thank you so much again, Dinesh, and appreciate everybody's contribution.
Thank you.
Thank you, Dinesh. Thank you, Dinesh.
Thank you. Thank you. Thank you.